So welcome everybody. It's the last day of our week of conferences. It's a day after many words. And I've heard a lot of people talk about what can we say came out of this conference, what were the highlights? And it's as many different opinions as it is people I've spoken to. And it probably is quite significant for the place we're in terms of HIV and health today. I'm speaking to you as an old lady, really, retired from public service. I was working with the Ministry of Foreign Affairs in Norway as an AIDS ambassador at the time when some governments that wanted to really make a difference in HIV wanted to have an ambassador. Now I'm sitting at the senior office in the National Institute of Public Health in Norway, but I'm also chairing the Robert Carr Civil Society Network Fund that some of you have also heard about as a tool for empowering key populations and inadequately served populations. And if it's anything we've heard about in this conference is unless they are part of or drive the response in the different ways that the different situations where they live and meet barriers and resistance, we're not going to achieve what we hope to achieve. So we're here then with a very strange title, Beyond Business as Usual. And I asked the organizers of this meeting, has AIDS response ever been business as usual? Because we've somehow been business unusual all the time. And it may indicate something about the way we now see the crossroads where we are. Somehow that we've found a way to do things and suddenly we need to do something different. But I think then it's also the next part of the title that speaks to us, addressing complacency and fatigue. Did the organizer think that we came in here for this conference fatigued, full of complacency, not really having the energy to expect change? And we're here now to answer that question, I think, because we're at the end of the conference and we have different answers to that. But if it's anything we hope to do in this conference is to help each other identify what can awake us, where are opportunities to move in this very complex environment. It's many stories, lots of diversity, and I'm just having some excellent people in the panel here, among them a journalist. And I'm expecting her to tell us, how do we make sense of complexity? Now, how do we formulate the challenges that will take us out of complacency and fatigue in order to say, yes, complexity, we can't deny complexity, we have to act in complexity and find a way to link together. And that's probably what bridging is all about. I don't want to take any more time to frame this question. I think we've definitely have strong voices all the week about treatment and service access, about the epidemiology, the challenges we face, sort of slowing down, but also very much in terms of stigma, discrimination, rights, criminalization, and in many ways some of the action areas that used to be treatment now is also now complemented by voices saying decriminalizing now. rights now, linking up with the gender movement, with all others that look for rights, look for empowerment of people where they are. So let's not talk about people-centered services as something simple, because everything we say about people, everything we say about community has to do with listening, learning, responding in ways that overcome some of these barriers, enable people to make the best use of their situation and fight where they're restricted from their rights. So with those words, I'm happy to welcome you all here. The way we'll do it, we'll have our introduction. We still miss our first speaker, Chris Bader, and we'll fit him in. Hopefully he will come. But I have other good speakers at the table here. And Andrew Ball from WHO has been willing to take the first go. But the purpose of all this presentation is not to recap everything you've heard, but is to bring up within all what we've heard, what does it take to move forward? So with that, I will introduce the panelists as we go, but we do have Andrew, we do have Erika Castellanos, we do have Ulaide Akani, and we have Eiji Hinoshita, and we just, here he comes. Everybody knows that you're too late. Okay, so that's, now you have to, let's make this a bit informal. You know, we don't need to, I'm sure you will apologize, but you will also let us know whether you want Andrea to go first or whether you should do what.
Please.
Okay. So let me introduce Andrew Ball, the Senior Strategy and Operations Advisor, Department of HIV and Hepatitis at WHO headquarters in Geneva, and he heads up Policy, External Relations, and Resource Mobilization Unit. In a way, you know, it doesn't make sense to go through all the wonderful things that Andrew, those of us that have been around have seen him in very many capacities. But what we know is that his engagement in very specific areas where we are really having challenges, substance dependence, adolescent health, and sort of now finding a way to steer the HIV response in conjunction with all the other good things we'll do with universal health coverage. So, Andrew, please come here.
Thanks very much, Sigrun. You know, we are at the end of a conference. Already over the past week, we've heard about how we are way off track to achieving the targets, the 1990 targets for 2020 and ending the epidemic by 2030. And I've also spoken to a lot of colleagues that I've been working with for decades, actually, and there is some fatigue there. But I've actually come to this conference actually feeling invigorated. Just to let you know that at this conference, it is the highest level delegation that we have had from WHO at any AIDS conference. That WHO has been responsible for putting on more sessions at this conference than any previous conference. So that's a clear indication that out there in the public health world, there is still great enthusiasm for the HIV response, but not only for the HIV response, but how we can actually incorporate HIV into the broader Sustainable Development Goals and that of universal health coverage. Now, in my presentation, I'm just going to focus on 4 points. Firstly, to say that, and I've been asked specifically to talk about transformation of health services so that we can actually make a difference. And I want to make 4 points. Firstly, to say that we actually have to contextualise the way in which health services are transformed. We have to ensure that the whole agenda of improving health services is fully integrated into any HIV strategy or broader health strategy. Secondly, I'm going to propose that integrated people-centred services provides the perfect framework for us to actually achieve health equity and to provide holistic services to those who need them. Third, I'm going to say how quality of services is of critical importance if we are to achieve greatest impact. And the fourth point I want to make is that we are thinking very differently about how we can adapt health services to actually be more efficient, to be more acceptable, and to actually be able to be scaled up to achieve the targets that we need. Now, positioning health service reform into the bigger agenda, we can see that in May this year, the World Health Assembly adopted a new strategy for WHO, a 5-year strategy. And the first strategic priority of that strategy is to have 1 billion additional people having access to universal health coverage by 2023. So this is all about delivering health services to people who need them. And central to that is the concept of universal health coverage. And universal health coverage means that all people receive the health services that they need, that are of sufficient quality to have impact, and in accessing those services, they should not experience financial hardship. And when we consider universal health coverage, there are a number of frameworks that we need to consider. Universal health coverage means that we deliver high-impact interventions across the full life course. So we have packages of interventions that we can deliver to pregnant women, infants, children, adolescents, young adults, and older adults. And that these services, these interventions, these high-impact interventions need to be strategically delivered through different levels of the health system. And that includes tertiary care, primary health care, outreach services, and very importantly for HIV is community-based and multi-sectoral services. I have heard in this conference a misconception that universal health coverage just means we're talking about services delivered through the state or government services. That is not the case. It does include community-based services and ensuring that those services are fully financed. When we talk about universal health coverage, we have actually incorporated the concept in the latest global health sector strategies on HIV, hepatitis and STIs. And let us not talk about single diseases. Let us start talking about common platforms whereby we can deliver against a broad range of health needs and diseases. And within the global health sector strategy, central to that strategy is Strategic Direction 3, which is delivering for equity. And this is all about how can we reform, how can we adapt, how can we transform health services to ensure equitable access and the greatest impact. And we also know very well from this conference and before about how we need to deliver services right across the continuum of care needs, from prevention, testing, linking to care, treatment, and chronic care. So a program is incomplete unless you can deliver across the full continuum. The second point I want to raise is that of the importance of people-centred services. And you can see in 2016, the World Health Assembly adopted a new strategy, which is one of integrated people-centred services. And this means that this covers 5 key components. Firstly, the importance of engaging and empowering people and communities in the response, in the design, and in the implementation of services. Second is strengthening governance, accountability, and financing of services so that we are delivering against standards, that we are channeling finances appropriately, and that governments, communities, services are being held to account. Third, we are talking about reorienting models of care. The HIV response has seen an incredible development of services that never existed before. From the 1980s, if you look back at the evolution of an incredible diversity of services that have been developed to reach different populations, to deliver some of the most controversial interventions you could imagine in a way in which they have greatest impact. So we have been pathfinders for many years in looking at reorienting health services. But now I believe is the time for us not to be complacent and to actually look beyond HIV to what is happening elsewhere in other areas of health, which are also providing innovation in transforming health services. Okay? Coordination, integration, and linking and alignment are key elements of people-centred services. And as the Director General said in his plenary speech, it's no good just to deliver HIV testing services to a sex worker and not to provide cervical cancer screening. We have seen when we are rolling out male circumcision that there is major problems with regard to coverage of tetanus vaccination for adolescent boys. So we need to go beyond just HIV services. And finally, looking at creating enabling environments, which is going to be critical in the policy, legal, and regulatory frameworks. Now, just very quickly, and I'm not going to go into any detail, but just to mention that now, as we have designed specific HIV services, there is going to be much greater focus on ensuring the quality of the services that are delivered. And you can see here that WHO is coming out with strategic approaches to ensuring mechanisms for improving the quality of services. Quality is now being integrated into our HIV guidelines to ensure that this is not forgotten. It's not just about the individual intervention, but the quality of services. And then the final point that I want to make is that we now have the expertise to actually design very tailored and specific services that are going to achieve the greatest impact. And here we're talking about differentiated service delivery, and there's a whole session that's ongoing at the same time about that. And these differentiated services actually will be able to define for a particular population and location what is the frequency of a particular intervention that's required, where that intervention should be delivered, who should be delivering that intervention, and what is that a particular quality of that intervention. We need to also consider elements about, for example, the characteristics, stable populations, looking at different populations such as key populations and the context. And then finally, this demonstrates how sophisticated now we are looking at designing specific interventions that can be tailored to the needs of specific populations. The one word of caution is that we cannot have complexity result in a major barrier to actually scale up. So let us get that balance right, tailoring the service, but not having it too complex that we can't deliver it appropriately. Thanks very much.
Let me challenge all of you now, because now you've heard a presentation that sort of presents the views of what it should be like. Integrated quality services. I'm sure all of you know it doesn't come by itself. People-centered care. You know, how long have we had a discussion of integration? How long has the HIV community been worried that integration means losing focus? How much don't we know about discrimination in healthcare? And I'm just challenging you so that if we should come out of here with a focus on where we move forward, ask those questions to the panel, but also to the audience and to yourself. What does it take? In designing the health services we heard about, who should be at the table where? And we have heard in this conference that unless the people who are now at the margins is part of making the design and finding answers to this difficulty, and I'm sure that Andrew is very much with me in saying that, that's when we can make the dream and the vision and the strategy of WHO come true in a way that it makes a difference for HIV and TB and for all of us. So I'm just saying this now, not to ask specific questions to Andrew, but to inspire you to think when you hear this presentation, what does it mean? Because we don't want to come out of here just with words. We want to come out here with sharpening the questions and what does it mean as we go forward. Let's go to our next speaker. Since he came late, I won't spend a long time introducing him, but you know him anyways from the US, past president of IAS and professor in epidemiology and working out of Johns Hopkins. And I think his team is very important to the understanding of where do we go from here. Please.
Well, good morning, everybody, and I want to thank my fellow panelists, but I also really want to thank all of you for being here on the last day. And you know, it's been quite a week, and it's really nice to see that people are still here, still engaged, still paying attention to these issues. I thought that one of the real advantages of being in one of the last sessions at the end of an extraordinary conference like this is that we get to reflect on what we've heard. Right? We get to think together about some of the new science and the new ideas. I'm sure everybody is in that process now and trying to pull it all together. Often it takes, you know, quite a bit of time after one of these enormous gatherings of our community and presentation of science from all over the world for kind of the key messages to emerge and for the key science to emerge. And I'm sure all of you have the same experience that I have, which is that you got to see about 1/10 of what you intended. So I would encourage you to the rapporteur sessions for all 5 tracks will be today. They are enormously helpful to sort of catch us all up on everything we missed. But we also make those available online. They're on YouTube. And so, you know, when you're back home and you have some time, it's great to go through those. I always do it and really try and pull out what happened at this conference. In the areas that we're addressing this morning and that Andrew just spoke to and laid out so nicely the framework, I just really want to talk about a relatively small number of presentations and outcomes that have been a part of AIDS 2018 that I think have some bearing on the topic in front of us and on the ways forward in the response, and that are, I think, really, really challenging and exciting. So the first is, how many people were at the presentation of the SEARCH trial results? Anybody get to SEARCH? Oh, good, a couple of people. So I'd love to hear your responses as we move to the panel phase. But, you know, SEARCH was co-led by Diane Havlier and Moses Kamya, Kenya and Uganda, an extraordinary effort to try and get out of the clinic space and get out into communities to do integrated screening for HIV and non-communicable diseases, including hypertension, and particularly to have a major focus on reaching that, nobody wants us to say hard to reach population anymore, but let's say less engaged in healthcare population, which is men. And of course, in the East African, Central, West, and Southern African regions, we have much higher engagement of women in the healthcare system, as you know, than men, particularly of working age. And that's been a challenge for us, and it continues to be, because it is men of working age who are also at risk for HIV acquisition and transmission. So search, the first results were presented here. There was a lot of enthusiasm and expectation around this. And the first thing to say is that there were real and measurable clinical benefits for people living with HIV. There was an extraordinary increase in male engagement and male testing. And it does seem that there were some wins on having, for example, hypertension screening, which is not a stigmatized disease in most of these cultural settings, being a way to address that stubbornness of HIV stigma that we've all had to deal with for so many decades now. So I see that as a tremendous advance. But also, they picked up an extraordinary amount of previously undiagnosed hypertension. So that's a win. What does it cost to do that? It's a blood pressure, right? And you know, one person described this to me in a phrase that I'm going to use. I'm going to use it for the first time now, which is, we've left so many things on the floor. How many HIV tests have we done? You know, millions and millions, and you know, you can't also take a blood pressure. So that, I think, and we have to remember that Kenya is a country with an enormous burden of hypertension and untreated and undiagnosed hypertension. So that is, you know, that's an example, I think, of a win-win. Now, it should also be said that they did not necessarily find the decline in HIV incidence with the increase in HIV treatment and viral suppression that people were hoping for. Some people are going to see that as the headline. Clinical outcomes for people living with HIV and better ART coverage are important in and of themselves, right? That means people are going to live. And that also means that they're not going to transmit. It is, of course, much harder to see an incidence impact. And it does appear in more careful analysis of these data, and you're going to hear a lot more about this going forward. There'll undoubtedly be more analyses, that migration and mobility played a big role, particularly in the Ugandan context. That has been an Achilles heel of a lot of our efforts for a very long time, and I think we're going to all need to reflect on how we need healthcare systems that can respond better to mobility and migration. Right? We've never had more people moving and out of their homes than we have now, and we had an extraordinary statistic in a presentation from Peter Piot in his plenary on our Lancet Commission, which I'll get to in a moment, that people who are residing in a country not of their birth or origin are the fourth largest country in the world. Population is equivalent to the fourth largest country in the world. So we have to start getting smart about those things. The second study that I think is not so much a study, but outcomes that are really important was in the PEPFAR pre-conference. I don't know how many of you were there. It was a spectacular 3-day conference this year, and we're so grateful for that wonderful partnership with PEPFAR and Ambassador Birx and her team. But there were some not great outcomes from several countries that have had substantial government, host country government or in-country government, and PEPFAR resources. And a good example is Côte d'Ivoire, where the mortality declines are much too slow, where there's clearly problems with uptake, with retention and care, and where we're still seeing unacceptably high amounts of people dying of AIDS. And it really does look like that the fee structure there and the structural reforms that were imposed, it must be said, by the IMF and the Global North, remain a barrier to accessing services. And all the PEPFAR investments, which are in the multi hundreds of millions, I think over the whole course of it in the billions, cannot address that structural problem. So that's a healthcare system policy reform that needs to happen to improve HIV services, right? You're supposed to applaud at that, yeah. Finally, I just want to talk briefly, as I think we want to open this up and be as interactive as we can, about the IAS Lancet Commission that we launched last night. Some of you may have seen that we did pre-media briefings, and we actually launched it when registration opened. This was in all of your registration packets. It's only 25,000 words, so I'm sure you've all read it thoroughly. But when you get a chance, please do. I think we really tried to think about the next steps in the HIV response, and to be very granular, using some different kinds of models about some of the potential integrations. And we used in 2 countries search data to help understand this and populate it. And remember, these are modeled outcomes. But we saw in the Kenya modeling wins in HIV treatment and in diagnosis and treatment of hypertension and diabetes by having an integrated screening across those 3 diseases. And happily, Brian Weir, who's in my group at Hopkins, worked with a number of people and a number of the commissioners on cost effectiveness, and these were highly cost effective. And really looked like they helped address particularly the hypertension burden, undiagnosed hypertension. We also looked at one integration scenario that ought to have happened across the world many years ago that is a no-brainer, but nevertheless, Nigeria, which, as many of you know, now accounts for about 30% or a little more of all perinatal transmissions worldwide, which is extraordinary, and which has extremely high fertility per woman and unacceptably high maternal mortality. And so we thought, okay, this is a place to look at the integration of contraception, family planning, PMTCT, and sexual health and rights for Nigerian women. And that, too, it turned out that the model looked like substantial reductions in perinatal transmission, substantial improvements in maternal outcomes, and very importantly, substantial reductions in unwanted pregnancies. So unwanted and unintended pregnancies prevention is also prevention of mother-to-child transmission, right? And so that, and by the way, was it cost effective? Highly, highly cost effective. Contraception is incredibly cost effective, as everyone who has been advocating for contraceptive access for women will tell you. And so, yeah, can it be that we're debating this and talking about the science of it in 2018? But yes, it is an unmet need. The unmet need for contraception in that country is enormous. And that is, again, a health system problem that I think we can fix, and that is galvanizing, hopefully, for the next phase of the HIV response. And we have to do better for those women, those families, and those infants. Finally, I just want to say that everybody is concerned, and people are right to be concerned about the concepts of integration and looking more at global health and universal health coverage and what happens for people who are not welcome in health systems, like people who inject drugs, sex workers, trans folks, men who have sex with men in so many places. So we looked at Russia, and we modeled Russia data and looked at what an integrated services package that included substitution therapy, antiviral therapy for those living with the virus, needle and syringe exchange, and overdose prevention measures, including community distribution of naloxone, what that could look like in the very expansive and out of control epidemic among injectors in 2 Russian cities. And not surprisingly, you get extraordinary wins in declines in new HIV infections. Over 10 years, you can reduce overdose deaths by a third. And we saw really quite impressive and exciting cost effectiveness. This is incredibly cheap to co-locate those services. So in that model, integration is not about saying that people who inject drugs should be in primary health care, where they are totally unwelcome, but rather that integration of services means doing better for people with the services they actually need and want, like needle and syringe exchange and substitution therapy. And I don't have to tell this audience that, at least for right now, that is an impossible scenario to realize, because substitution therapy, methadone and buprenorphine, remain illegal in the Russian Federation, and we can't deliver that most basic of services. So that, again, is a health system structural reform that could have a huge difference in HIV outcomes. And I would argue that without it, they're not going to be able to control that epidemic. So I think, you know, as always, science is exciting. I hope you're excited about the science of this conference. And I think we've had a lot around what the future is going to look like that we need now to take out into empirical, evidence-based studies and do what we've always done in this movement: be stepwise, be evidence-based, keep people at the center of what we do, respect human rights, and work together across disciplines. Thanks for your attention.
Thank you. Now we hear Chris uses the word of health system reform when we look at some of the structural reasons why people don't come forward. I think a lot of you would talk about legal reform, dealing with issues way outside the health sector, and that we can't rely on health professionals to fix it. So again, let's explore what that means to move into these areas where we clearly have some major gaps. Now my two first colleagues were not that good in keeping time. Now I'll have two women on the panel. And if they go over time, I'll let them go over time. Because the men did. The first speaker is Erika Castellanos from Belize and living here in the Netherlands. She is an amazing woman who is now a member of the board of the Global Fund. We need you there, Erika. She's also the co-chair of VIV's Positive Action Program for MSM and transgender people. And she's actually herself the first openly transgender advocate to be appointed to the Global Fund board. So we're so pleased that you are here with us. And please share your experience and also be clear on where change needs to come.
Thank you very much. Thank you very much, but I don't think I'll go over the 10 minutes. Women are very good in timekeeping. So I was asked to address how serious are we in reaching the hard to reach. And you know, it's really hard to put it in a scale or give it a number or a percentage or grade us about it. But I'll start by saying my personal opinion and my personal view about it. I think we're not serious at all. Not at all. There seems to be a great interest, and I'm going to speak on the point of view from key populations. There seems to be a great interest to work with key populations. Funders seems to have us as a priority. But are they really funding what we need to be funded for? What we are asking, what our needs are? I know many times the decisions of what is funding is based on good intentions, but without our voices, good intentions will not fill the gaps of our needs. And in this conference, a few days ago, I was asked a question. Erika, can you help us convince some trans people in a country that they should concentrate on their ARVs and stop demanding hormone therapy? And I said, I'm sorry, I will not do that. Mm-hmm. Because we shouldn't be put to choose between one and the other. Mm-hmm. If I've been living with HIV for 22 years, but if I would today be given the choice between one or the other, I prefer to live one day as the person I am than live 10 years as the person I am not. But mainly, when you hear hard to reach, I ask myself, what the fuck is that? There's nothing hard to reach. It's how you try to reach people and who is doing the reaching. Definitely, if you let communities reach our own peers, we can definitely reach them. It's not impossible. So this is a lesson, and I think we have seen it and heard it over and over, not only in this conference, we've been hearing it from several countries, that peer-led interventions work, that they are effective, that we should be in the center of the response. So what is keeping us from actually implementing it if we know it works? We hear about meaningful involvement, and we have a policy about, the meaningful involvement of persons living with HIV, the JIPA policy. Why is it that we are not embracing it if we know that it really works and it is needed? Our voices need to be at the center of the response. Our needs need to be at the center of the response, or else this is what happens. We're far away from reaching the goals. And it has we are in this difficult position because we have failed to accept the evidence we have right in front of our faces, slapping us every day. And this is something that we really need to work on. But we really need to work in a different way. I sometimes think that as an activist, and I'm going to criticize our own selves as community now, because it's always good for us to criticize each other and ourselves. There's a need to reactivate activism. Because of my age, I can remember the days, in the early days in Latin America, when we were fighting for medicines. And there was so much activism, and we were united. You know why? Because we needed those medications to stay alive. Somehow that spirit, that passion is slowly being complacent, because now we have the medicines, okay, we're alive. And in many countries, like the country I come from, because the government provides it for free, you feel like you're in debt. And we shouldn't feel that way. It is our right. But nevertheless, there's so many other issues. Every time there are new challenges. And we shouldn't let go of the passion that has brought us where we are today. Because if it was not for us, the community, we would have never reached so far. Therefore, we should not lose any momentum. And this is the moment that we should again ignite that momentum in our community and be able to move forward. We owe it to the new generation. We owe it to the people who are still getting infected, new infections. This is something that can be stopped. And I get so angry when I hear epidemics rebounding in different countries. I also have a hard time when every year countries report continuous and increased deaths among key populations due to HIV-related illnesses. It's totally unrealistic. We have all the tools and the evidence so that no one has to die of HIV complications, and yet we are allowing it to happen. I think one of the things that we always say is, we need more data and we need more data. And there has been a push to involve community in data. But so far, the majority of that involvement has been as data collectors. And I don't think that's enough. That is definitely not enough. We need to be involved in the design of the study, in the implementation and the analysis and the presentation of the results of the studies so that we own them. Because if we are not involved, we will not own them. Lastly, I want to say, as key populations also, we need, and as community, in general, we need to stop working in silos. I know we all have our objectives and we all have our particularities, but we need to work together. We need to work together with the scientific community. We need to work together with our governments. And we need to build on our strengths and our similarities because we are all affected. So I just want to end today with a call for all to unite. Thank you.
Thank you very much, Erika. And we'll need to come back from all the panels as to how to make that inclusion and at the core of everything we do real. So the next speaker here on my panel is Ulaide Akani from Nigeria. She is a journalist, and she is the executive director of an organization called Journalists Against AIDS, and has been working very seriously over many years in promoting literacy, but also I think what's been very important, what you've been doing, Ulaide, is also with ITPC on the Missing the Target report, and also shadow report on the country coordination mechanism, and having those eyes to watch what is really happening as a contrast to what we hope will happen, and which information covers up and which information reveals. So we look very much forward now to hear your views as to how we go from here. I suppose you will challenge us in a way that we wake up. Thank you.
Thank you, Madam Chair, and thank you to everyone who is here with us to listen to us and interact with us in the session. Very quickly, I think it's important to acknowledge the role that people living with HIV have played and continue to play in the response, and we really very much appreciate that. So going to the topic of the discussion, I think that first of all, we need to rethink our framing of the response. We've said a lot about ending AIDS, and sometimes the flip side of that is that terminology even fueling complacency? We need to think about that, because if people are saying, oh, we're ending AIDS, so people think, oh, maybe there's really not much to be done anymore. Is AIDS really a problem? Should we really be putting all of our energies into HIV and AIDS interventions? So that is something for us to think about. Our framing of that term, ending AIDS, is it fueling complacency? The second thing I want to talk about very quickly is what Dr. Peter Piot had said in the plenary on Thursday, and that's the importance of having a long-term view with respect to the HIV and AIDS epidemic. We cannot afford to have a resurgence, and we're seeing new cases happening over and over again in young people, and we shouldn't allow that to happen. And so if we're going to look at HIV and AIDS in totality, we need to have a long-term view. We cannot afford to say, oh, we're there. It's no longer, like we have said over and over again, it's not a sprint, it's a marathon. And we should be ready for that marathon. We should be ready over the long haul. Closely linked to that is the issue of long-term investment. I know that some donor governments don't want to hear that anymore, like they feel like, okay, we've done enough, but really, we know about the 10-10-10 that still may not be reached, and we really know that they are the ones who are going to change the face of the epidemic. So we really need to go the long haul and not allow ourselves to become tired or fatigued as we respond. And closely related to that, as we're responding to HIV and AIDS epidemic, is the fact that in this conference, we've heard so much about comorbidities and, other infections that are cropping up in many countries. And so we really need to look at what are the opportunities, and several opportunities are existing for linkages and working together. During some of the poster sessions, I saw in many countries how people are going innovative, how community groups are being more innovative in offering HIV and AIDS testing services. They're also offering testing for blood pressure, for a whole lot of other things, for cervical cancer, and a whole lot of other things that, people need to have access to. And it's important that at country level, we're looking at the multi-sectoral response. I know in HIV and AIDS, we've been a key driver of the multi-sectoral response, but we also need to bring all other health other diseases on board. And that's why the discussions about universal health coverage and the linkage between HIV and, pushing for universal health coverage is very critical, and that discourse needs to happen. But beyond the discussions that we're having in these conferences about integration, the concern is what exactly is happening with integration at country level. More often than not, we talk about, the linkages between TB and HIV. But we know that even at country level, some of the programs are still not talking to each other as they should. There is still a huge gap. I'm happy that in this conference, we had a huge pre-conference where we talked about TB, and that is a lot of progress. But beyond talking about the linkage in this conference, what happens when we get back home? How integrated are the TB and the HIV programs on the ground at country level? And how integrated is HIV with all the other disease, the non-communicable diseases? And we really need to think about how we make that happen at country level, because if we don't make it happen at country level, it's not going to happen. We can talk about multisectorality over and over again, but we really need to look at the systems in place. And the previous speaker talked about moving away from the silo approach, and that is a big issue as we go into our countries, as we go back from here. How do we ensure that the policy frameworks and the guidelines actually are enabling for disease-burdened areas to be talking to one another? Because the important issue is, it's all of this disease actually happen in one person. Most oftentimes than not. And how do we look at that patient-centered approach from the person's perspective, like the previous speaker had said? Because it's important to look at that. I remember that as far back as 2003, I had attended a TB conference, and that was my first introduction to TB. And in that conference, one of the speakers talked about her experience with TB and her experience with living with HIV. And for the first time, I was seeing that these were actually two diseases happening in one person. And as we go forward, we realize that there are many diseases happening in one person. And how do we ensure that those linkages really happen at country level is critical. So we need to look at breaking the silos at country level. We also need to look at long-term investment. But one of the other important things I want to highlight was a statement made by a young person at the opening plenary. She gave the example of a bridge in Honduras and the fact that the river had shifted. And so the question is, are we building bridges that are leading to nowhere? Or how do we build bridges that are actually leading to somewhere as we go back? Are we still working on the old bridges, or are we going to do things differently at country level? And that is very important as we go forward to say, beyond these conferences, beyond the talk shops, beyond what we do and the knowledge that we have gained, how do we make this a reality at the country level? And the patient-centered approach also looks at the community. We know that the community has a critical role to play in reaching the unreached. And in many of our countries, the community, civil society actors have gone, the last mile. They go the last mile to ensure that people who are unable to access the health services are brought closer so that the health services are delivered to them. So beyond just talking in these meetings and saying we're going to do this, we need to go back to our countries and actually look at our health programs and look at how people-centered they are, bring people together at the table. And the multi-sectoral approach that we have utilized in the HIV and AIDS response is very, very critical as we go forward. How do we ensure that even as we're designing our designing the implementation of UHC at country level, the multi-stakeholder dialogues that are supposed to happen need to bring all of the stakeholders on board to say, how do we ensure that we deliver services in such a way that people are not impoverished? Because in many of the countries that we live in, the out-of-pocket expenses are still very huge. People cannot afford the services that they require. And we know that because health is a right, an individual is not supposed to choose between food and access to health, because health is a right. We must ensure that health services are affordable and systems are put in place to ensure that irrespective of the kind of health services you need to access, the systems are there and the systems are available to ensure that people can access those services. And lastly, like I mentioned earlier, we're in this for the long haul. So we must have that long-term view. And that long-term view means that, we're looking at the financing part of things, we're looking at service delivery, we're looking at sustainability, we're looking at, the structural barriers that are currently limiting people from accessing the services. And how do we ensure that we actually put in place an enabling environment? The legal barriers that are dividing us and are restricting persons living with HIV, people who inject drugs, and key populations from accessing the services that they really need to be looked at and examined critically, because beyond the barriers and beyond all of these restrictions are people. Behind the barriers are all individuals who need to access care in a non-threatening manner. So it's very important that as we go forward, we look at building barriers, overcoming those barriers and really building bridges that will enable people to access the services that they need. Thank you.
Let us remember that the restrictions that you just talked about are not just happening. They're willed restrictions. We talk about a political will to do good things, but we also know that some of these restrictions are policies and decisions that is willed by governments and by the population at large. So you also mentioned people-centered approaches, and comparing with what Chris was talking about, what is a health reform issue, certainly people-centered approaches of healthcare. That's a basic healthcare issue. It's for us professionals, how we treat people, how we think about our own. So I think that, again, we have to keep in mind your question: how do we raise, how do we assess, how do we find out what doesn't work in these systems to make it people-centered, because it won't happen by itself. That's not the tradition of medical services, that it becomes people-centered. It needs to be pushed, and as we heard about, also with space for those that are at the margins and are actually experiencing restrictions. We have one more presentation. I really hope afterwards that instead of having a long discussion here, that you will be prepared to add your questions. And even if we're not able to come out with a consensus statement on how do we get out of complacency and fatigue, I think if we have some of those questions in our ears as we go out, it sort of forces us to listen more, act more, deal with ways to build these bridges we're talking about. The last presentation is from Japan. I'm sure you remember that the G8 meeting in Okinawa in 2000, just after the AIDS conference in Durban, was actually the start of the Global Fund, and also how Japan has been a champion of universal health coverage for many, many years. So what is more appropriate than having Eiji Hinoshita, who is now the Director General for the Bureau of International Health Cooperation in the National Center for Global Health and Medicine, and also an alternate board member of the Global Fund. He's been around in the Ministry of Health, he's been around in the Ministry of Foreign Affairs, he's been in the UN, he's a medical doctor. We look forward to your presentation, but also it's being set in the environment of Japan, with aging, with a very advanced healthcare system. And we will see from that side, what does it mean to move forward in the HIV response, but also how to link it with their general system. Please.
Thank you, Madam Chair, and thank you for giving me an opportunity to present Japan's perspective of healthcare for HIV/AIDS. This slide shows the newly diagnosed HIV/AIDS positive cases in Japan. As seen in this slide, and the total number of newly diagnosed HIV/AIDS positive started to decrease since 2013, but we have still 1,400. So we cannot stop our effort to decrease the number of newly diagnosed HIV/AIDS. With a point of view of surveillance system, we have several problems. The first one is HIV positive has been expanding in a male homosexual contact group. So specific measure is required for MSM as a high-risk group. The second point is about 30% cases are newly diagnosed after developing AIDS. Especially in the rural area, the majority of the newly diagnosed HIV positive is after developing AIDS. So special response is required depending on the situation or the location. The last one is the majority of the newly diagnosed HIV positive cases are from 20s to 30s. And the newly diagnosed AIDS positive AIDS cases are more than 30s. So Japan has a special concern about HIV infection expansion among 20s. Now, I would like to share with you the HIV/AIDS response in Japan. Japan's response to HIV/AIDS have been implemented under the AIDS prevention guidelines, which was made based on the Act on Prevention of Infectious Diseases and Medical Care for Patients with Infectious Diseases. Previously, the Standalone Act on HIV/AIDS Prevention and Control was existed, and as well as Standalone Act on TB. But those acts were integrated into one comprehensive act. Now we have a new Infectious Disease Act and established a new AIDS guidelines. We periodically review and revise the guideline, and we made 3 revisions. In those revisions, we made a big change in the second and third revision. In the second revision, we made a big change of a concept of HIV/AIDS from special incurable diseases to common controllable diseases. At the third revision, which was made this January, we changed to strengthen the healthcare system in order for people living with HIV/AIDS to access the necessary and enough healthcare at the community levels with a point of view of long-term care and welfare services. As you may know, Japan achieved the universal health insurance system in 1961, and all the Japanese people can access to necessary healthcare services, including NCDs, HIV/AIDS, without any financial hardship. Moreover, immunodeficiency caused by HIV has been defined as a disability under the Act on Welfare of Physically Disabled Person in 1998. So, HIV positive is subjected to a kind of disability whose medical expenses are paid by the public as services and support for persons with disabilities. Now, I would like to share with the healthcare provision system for HIV/AIDS. The HIV/AIDS positive patient can receive their adequate and enough healthcare service at the community level, especially in central hospital at the community level. But in in central hospital, they're necessary, do not have all department. So in some cases, they refer to the regional AIDS centers or the AIDS Clinical Center, ACC, which is at NCGM, which is a top center of healthcare provision system for AIDS in Japan. And in order to reduce the burden of such kind of referral work, we newly made the core hospitals at the prefecture, at the region of the each HIV positive patient are living. So we made a comprehensive referral system for HIV/AIDS positive. As a result, with the benefit of such kind of financial protection and the healthcare provision system, we achieved more than 99% viral suppression of HIV/AIDS increase, and can secure the access to healthcare services. But in spite of the benefit of such kind of financial protection system and the healthcare provision system, we do not have the access is just 90%. So we have to increase this access. Maybe the barrier is the discrimination or the discrimination. So we have to enlighten and we have to secure the testing for strengthening the importance of the having tests for those who do not know their HIV infection. Thank you very much.
It's very interesting, isn't it, that even with this system, even with the kind of public provision, we end up with an access problem. If we translate that to the whole world, we also know we have huge adherence problems, even if you access treatment to stick to it. And in Japan, realizing that discrimination is real. And that, again, let me come back to the real critical issue that really should push us forward. And that's what we've heard through the conference on discrimination in healthcare, which makes it hard both to access and to adhere to treatment. And the more we go into the integrated care, the more it is an issue. And the more we talk about the SDGs in integration, I think Erika's question about what is the space for the people at the margins, I hesitate to call it key populations, but the people that really are not accessing services and know why and know how to deal with the barriers. Now, this is now the menu before us of the kind of challenges and opportunities that we've heard about that should drive action forward. And please now come to the mic and add your views on it, and you can ask the panel here, but you don't have to have a question, because this should be what really inspires us to go out of here and think, yes, we can. First, number 3 there.
Good morning. My name is Olya. I'm from International HIV/AIDS Alliance. Thank you to all the panelists, and I have a question for Andrew. Thank you for outlining and clarifying that UHC includes funding for community organizations to deliver services. I want to clarify whether the framework also includes plans for funding community advocacy and organizational development of the community organizations, because these are the organizations that often bring innovation, positive disruption, and can address challenges like, for example, those outlined in Russia. And I believe this is particularly important because as donors leave, this is the area that are really left behind without funding. And it's quite difficult to do innovation and really respond to key population needs without community advocacy and core organizational funding for communities. Thank you.
Thank you very much. And I will just hold the question so that we can get several up here. And I think I have one from mic number 2.
Hi, I'm Rubendra Prada with UNAIDS, working in Nepal, Bhutan, and Bangladesh. You know, colleagues, on this last afternoon, I challenged that we're facing a pandemic of arrogance, of hypocrisy, a pandemic maybe of fear, maybe it's ignorance. We're really establishing formal contracts between government and civil society as a unit for action. We still have this dichotomy, and this is why we have to continuously build bridges, because there is something between us, and sometimes that thing about between us is so broad. So unless we really have formalized cooperation and civil society contributing and attributing to the successes of HIV responses, we will also talk about us and them and having to build bridges. You know, I have in my hand the National Strategic Plan of Nepal and the document that's called the Community-Led Testing Guidelines. We actively looked for any mention of hard-to-reach populations. It's unacceptable that people are called hard to reach. Hard to reach by who? For who? So each and everyone in this room who has a national strategic plan of their country that has hard-to-reach populations mentioned in it, it's shameful.
Thank you. Isn't that your job in UNAIDS to keep on watching that?
It's out.
Let's hear from 6 behind there.
Yeah, I have some concerns concerning the date that has been set, 2030. I don't know the organization who set the date and for whom or where. Because you have about 37 million people living with HIV/AIDS in the world. And Africa alone has about 25 million people. So now, and if you look at the services in the countries that have less than the 25 million, and those in the African region, they are not the same. So when you set this date of 2030, on what basis are you setting this date? Because, for example, I come from Belgium. In Belgium, the last statistics of new diagnosis was 915 new cases. This is a developed country with all the good medication and a good healthcare system. If we have to go back to an African country, I will take another country like Cameroon. There you have about 30,000 people dying. That is official. A year from HIV/AIDS related diseases. So how are you going to try to stop new HIV cases by 2030 in a place like Cameroon?
Thank you for making that point.
And
I think
much.
also that's why we have to get real also that the world looks very, very different and needs to be really focusing on each of the locations and the global together. I think 3 was before 1, so I'll start with 3.
Oh, yeah, thank you very much. David Bryden with results in the U.S. This has been a really good panel, one of the best, I think, that we've had in this whole conference. And, you know, I just wanted to, thank the panel. And, yeah, exactly. Really one of the best. You know, we really need to work harder to build bridges. And I think some really good examples just really hit me in the face this week. I mean, I'm an advocate for integration, especially when it comes to TB and HIV. And I've been talking to people in the conference. I'll say to people, well, now, of course, you know that there is TB preventive therapy. There's what? That is the response? What is that? People don't even know. Programs aren't even being, you know, they're not even making people aware of it, much less scaling up something like a 1-month course of preventive therapy, 3HP, or a urine-based test. People don't even know that there is such a thing as a urine-based test. People are shocked and amazed when I tell them there's a urine test for TB. or even Menstar. I went up and talked to Menstar, which is a fantastic initiative, but I said, now, is there going to be TB screening, even a simple symptom screen for this in this program? Oh, well, yeah, we're not quite sure yet. I mean, how can that be? Or in the discussion about HIV in Eastern Europe, right? That TB should be a part of that discussion, right? So I'm kind of dumbfounded sometimes.
Thank you. Yeah. And I think that then we should ask ourselves, who asked that question in each of the locations where we're working? Because that can't be answered in a global movement. It has to be us that bring that to the forefront in these discussions where services are delivered, put together, and debated nationally. Then number one here.
Yeah, hi, I'm Kevin Moody. I live here in the Netherlands. I had the opportunity during this conference to facilitate discussions around the fourth 90, quality of life. And in part because of those discussions, I have really great concerns about the implementation of person-centered approaches. In the global north, we don't have that at all. And as Erica pointed out, we've had JIPA for decades, and we haven't really done a good job of meaningfully implementing that. So as we move forward, towards integrated, person-centered, outcome-focused services, how are we going to go about changing the power dynamics? How are we actually going to meaningfully put the person in the center? And when I hear the term differentiated services, this is what the community's been doing for years. And Andrew is right in saying that, in fact, this isn't sort of it's not owned by governments. But how can we ensure adequate investment in community-based integrated services, and how can they be integrated as a whole into the system?
Thank you for that reality check. And now we have two. If there is any more, yes, we have two more here. So please come to the mic if you have other comments. Two more here and one behind there. That's probably what we can cope with. Yes, please.
Hi, I'm Charlie Vanderhorst from the University of North Carolina. And first of all, this was a terrific panel. I'm very grateful. And I would like to say that as someone who's 66, and I took care of my first HIV patient before we knew it was HIV in 1980 when I was an intern in the United States, it's very heartening to be here and see so many young researchers and activists stepping forward. It gives me great hope for the future. And bringing activists to the forefront once again. A couple things, the ostensible title is Complacency and Fatigue. Okay, so I should certainly feel that, like you, Sigrun. We've been here for so long. And for me, I think the key things addressing several points that were brought up. So, for instance, research is very useful to combat fatigue and complacency. So, we hear the search data results and we're excited, but we also see that we got to go farther. That means we got to do PrEP. You can't just do test and treat. You got to identify people who are at greater risk and get them on PrEP. So that should be the next study that we do. You talk about there's too much silo. Certainly, as someone who's worked in Malawi and South Africa for 18 years, that is a huge problem, and unless we address that, we're never going to go forward. But Erica, I particularly love your call to activism, because I am an old white guy with power as a physician and a professor, and we can't just leave it up to affected populations to do the protesting. It's up to old white people to step forward. And I've been in the United States, I've been arrested twice for civil disobedience, but it needs to happen in Nigeria, that you need to speak out as a physician and as civil servant when you see that there isn't integration of services, okay? And until we do that, we're not going to be holding our governments accountable. We're not going to make progress. So we have to unite with the activists. We need to listen to them, as Erica said, and what their needs, and we have to join together and march forward. And together, then, we can achieve success.
Thank you. So, up at number 4.
Thank you. I thank the panel also. I think it was a great panel. And I came with such expectations. Elizabeth Mushabe with UN Women. I listened keenly to all the speakers. And yes, they all talked about almost the same things, but put them differently. And it was just the art of presenting this, which actually demonstrates the fatigue. I am then thinking, can we start to build bridges to explore new waters? For example, all of us talked about the capacities and abilities of the health system, the structures, how we deliver our health services. But has anyone gone ahead to explore and say, we have the state-of-the-art facilities, our doctors are excellent, we have professors, we have everything we need, but this woman will still not come to get services. Access is still a problem. Quality, I think like Andrew said, is of concern. And I think in your remarks, Madam Chair, you said this is basic. It's basic in health services delivery. But what has stopped us from delivering what is basic? What has stopped us from attracting communities to what we think we do best? I think it's the bridge we need to build. We need to stop these repetitions, presenting better acronyms and everything, and build this bridge. Let's have the bridge go to the structural issues, the communities. They have things stopping them. I can tell you there are inequalities down there. There are reasons that they will not come to these excellent facilities, to partake of these excellent services. And I think that's where we need to go, moving beyond our comfort zones.
Thank you.
Thank you.
So the last intervention here by two.
Okay, thank you. Thank you very much. Let me first thank the speakers for the wonderful presentations. They were really thought-provoking and giving guidance as well. I'm Margaret. I'm from South Africa, from the Department of Health, South Africa, in the Northwest Province. I want to talk like a person who has been in this program for a very, very long time.
Can you be closer to the mic? So
okay. With the questions that you asked, Madam Chair, I've been sitting down and thinking what you are saying. But I'm thinking that something somewhere is wrong. But the other thing that I have seen throughout this conference is that there is something that needs to be done within governments themselves. The government itself does not talk among itself. I don't know whether am I understood by that. I was looking at the issues that are impeding or defeating or making access very poor for marginalized and other vulnerable groups, that it is the government itself where legislation is not enabling policies to be implemented in certain countries. I think the government itself, different governments, they must begin to talk amongst themselves. If I am a country, I am South Africa, I am implementing such an important program, and my legislation, pieces of legislation in the country does not allow that to happen. I don't understand what I'm talking about there.
Thank you.
And
I think we got to stop there because I would like to let the panel, we have just
I will not
minutes.
go a lot then.
Yeah.
Okay. The second thing is that I think we need, maybe we are lacking somewhere with the healthcare system has become very complex with emergence of diseases like HIV and AIDS that required a lot of us to do as well as learning in the process. So I think we need to do something about the healthcare system itself. Do we have capable managers and leaders? I'm not saying they are not, but we need another level of management that will be able to link the dots and be able to carry up the system from where it is to enable it to function.
I think there is strong agreement on that and holding it accountable.
Lastly,
I don't think we can take any more points at this stage, but share with your colleagues and let us move forward. The last 5 minutes now, I think it would be good to have a very brief reply. You don't need to reply to questions, but your observations and your key sentence on how to move forward. And since Chris came latest, he can say his point and go first because he's really eager to get on.
That is. I'm sorry, I was greeting Congresswoman Barbara Lee. I forgot to tell you why, and she is here, and that's wonderful, and she's going to do a session on 2020 later. Very, very briefly, I want to just respond to Charlie. It's wonderful to see you here. We have the largest youth force and youth program, youth pre-conference for this conference, and I totally agree. The thing that is the most exciting and thrilling, really, is the participation of this next generation. And they are passionate about equity, they are passionate about social justice, they are passionate about sexual and gender minority rights. They're a thrilling group, and we need their infusion. I'd just like to respond also to the point about TB. TB, in my view, and the integration of HIV and TB is like the integration of PMTCT and contraception. How can it be that we're still having this discussion after so many years? And you're absolutely right in your points about IPT and TB prevention. And I think the high-level meeting, hopefully, this fall is going to be a real opportunity to galvanize that discussion. So thanks.
Thank you. Erika.
Thank you very much. I think one of the things that we heard today is the question about ending AIDS in 2030. Certainly, I would love it to end by 2030. And I think we need to put all our effort to it. One thing that challenged me today, the question was about how do we change power dynamics? And I think we really need to start looking at that very closely. And I will take advantage that I'm here and I say, Andrew, UHC might be an opportunity, but how do we make sure that JIPA is deeply integrated in UHC and it's very obvious? And, we need to be more inclusive. That's one thing for sure. And I just want to particularly call out a call from our trans brothers in this conference who have been calling out for the inclusion of trans men who have sex with men in the HIV response. We cannot forget them. And even as civil society, we have that responsibility. And the question of fatigue, we cannot afford fatigue. Every time a person dies, we need to renew our strength. There's no time for fatigue in our response.
Thank you. AG, do you want to have a short observation? Going home, doing things differently, what will you do?
Thank you very much. Formerly, I was engaged in the G7 Ise-Shima Summit and have a discussion about the silo approach and the vertical approach. For the silo approach, it is very important to collect enough financial resources, but it doesn't continue long. So we insist to implement the universal health coverage with a point of view of sustainability. In order to do so, we have a political leadership. So, but the political leadership is not in one country. The political leadership exists in each country. So each country have to lead to achieve universal health coverage. Thank you very much.
Thank you. Andrew?
Yes, thanks very much for all the questions and comments. There were a couple that were directed to me, so maybe I'll focus on them. And that is really the concerns that I have heard at the conference and prior to the conference about still communities being excluded from the whole UHC debate and agenda. And we don't see that as being the case. We see it as being a critical element of achieving UHC without engaging the community in a way in which we're going to ensure ownership and to have full involvement. We aren't going to achieve impact. We aren't going to achieve sustainability. And we are looking very concretely at measures that can be taken. There has been a UHC 2030 mechanism established whereby communities and civil society can engage in the UHC process to ensure that it's not only the construction, the thinking around UHC, but the actual delivery meets the needs and addresses the issues that you have raised. Just to be very clear, that UHC includes health promotion. It's not just about delivering of services through clinics. And we are now looking at ways in which we can go to countries with our health systems financing people, the disease-specific programs, HIV, TB, hepatitis, and say, okay, when you are looking at health financing reform in a particular country, we have to ensure that the HIV, TB, malaria, sexual reproductive health targets can be achieved through whatever mechanism is being discussed. And this means looking at how we can ensure that there are financing mechanisms in place to reach and to enable community action to occur. A lot of that is still going to be dependent on external funding, and we see Global Fund has, very significant investments in community strengthening. But we actually have to look at how we can transition this to governments taking responsibility to fund mechanisms that allow communities to take control.
Thank you. I think that this is a time to wrap up. I'm not planning to use many words on that. I'm happy that youth came in, because what I felt was missing from our panel was youth leadership. At least it's been raised by many. With some of us that have been around for a long time, we probably see that we have to let go now and have these questions raised by others and the youth movement and new ways of thinking. But when we talk about we need to ensure, I think what this session has been about is that we have to address what is stopping us at each level where we work. And if it's hard to access, and I think the UNAIDS comment was very interesting in the sense that UNAIDS need to be empowered to ask those questions. Groups like what Erika mentioned, all of us have to be sensitized to say, access, what is stopping us from access? Whether it's the medical side or it's the right side, and how do we share the knowledge about what happens? And some of the data isn't helping us. We need to go beyond some of the data we're having. And we shouldn't just say thank you to the Global Fund and then we fixed it. Because the way the money is used, whether it's PEPFAR, it's the Global Fund, the Little Robert Carr Fund, whatever, we constantly need to look at how do we invest in ways to overcome some of these resistance, restrictions, marginalization. And if it's anything I as a medical doctor would want to leave with you, it's we have to watch discrimination in healthcare. We cannot live with that any longer. Thank you all for a good discussion.